There are a committee of 10 people. We have made our prayers for that number to be increased. It was also in their work plan. So by the end of this year, we'll have new fellows. We'll also have good or high service awards that will happen. So we'll just ask you all to vote and, why do you feel the following have to be fellows or get those service awards? So without further ado, Professor Ndemo has been working closely with us with pharmacy benefit packages. Yeah, what that means is for the first time, you can, okay, let me stop for a moment. So right now, we might have the registered pharmacies are how many? 5,000. Of the ones that are manned by pharmacists, or at least registered by pharmacists, the number is 500. Yeah? This room we filled 800 people, and half of them were public sector. Yeah? So, if you are not in community, where are you? Yeah? That's number one. And why are you not in community? So the question, when we ask that question, we are told, I can't compete in the market because it's a price-sensitive market. Client just goes to where it is cheaper or something like that, whether it's quality or not. Someone has borrowed the license, all those things. You can't compete at that level. So we went a bit forward and said, okay, the government wants to reimburse services. So if you work in Kilifi, who are the people who have money in Kilifi? Teachers, all those people like hoteliers and all those things. Now all of them have to pay their money through who? SHA. Sindio? So who will be paying? It is SHA. So we said, how can we then have pharmacists recognized as service providers and their pharmacies recognized as health facilities? So that is what has been happening. So out of that, then you will have that. This thing will have two outcomes. We will kill quacks because now the person paying cannot go to quacks. It can only go to someone who PPB has provided a list and say these are the people and these are the levels of service that they are meant to be doing. I think that's worth celebrating as we live here. So please clap for yourselves because the input has really been, and the pressure has really been coming from you. So I'd like to give Honorable Professor Ndemo, how much? 10 minutes to just take us through what you've been doing.
Yeah, 5 or 10 minutes. Thank you, Mr. President. Actually, a lot of the things I was about to present have already been more or less like covered before, but I just walk you through. I was asked by the President to put together what we have been doing on the Good Pharmacy Practice Guideline, the GPP, and also the progress we made with SHA to ensure that we have a benefit package that includes the service model. So if I can have my objectives so that I can quickly cover it in 5 or 10 minutes. First, a lot of things, I need to define what primary healthcare is. Secondly, I'll do a situation analysis on what the country has done with respect to primary healthcare. Then I'll talk about a little bit in detail on the role of the pharmacists in primary healthcare. Then I'll give you just the highlights of what we have done so far with the GPP or GPPG. And then I will also make a last reference to the coverage of pharmacy benefits. You do realize in pharmacy we have both the product and the service. So my concern has always been that we should address the practice or the service component. So let me have the next slide so that I don't keep you. Now, literally reading, you can also read. Primary health, this was adopted from WHO. Primary healthcare is a whole of society approach, holistically, to effectively organize and strengthen national health system to bring services for health and well-being closer to communities. In other words, we're really talking about the first point of call in the community. That is, the services that are provided there are primary as opposed to secondary and tertiary. So they have 3 components. Number 1, they have to be integrated. Number 3, you have to address broader determinants. Number 4, you have to empower the individuals, the families, the community to take care of their health. That is actually the underpinning components for primary health care. But the fundamental premises is truly all people everywhere have a right to achieve the highest attainable level of health. That is the fundamental premise of PHC. Can I have the next slide? Now, the situation analysis. I will do the historical perspective. You talk about UHC, and lastly, I'll talk about the PCN, or the primary healthcare network, and then we can see how we can contextualize the PCN, which is used as a strategy to achieving UHC. Could I have the next slide? Now, in 2012, this is a UN agency, universal health coverage, or UHC, was adopted as a global priority. The resolution on global health and foreign policy, countries actually were urged to transition to UHC. UHC in 2015 was solidified as a central component on the SDGs, that's Sustainable Development Goals, and goal number 3, SDG 3, is good health and well-being, which aims to ensure healthy lives and promote well-being for all and at all ages. I've emphasized that for all and at all ages. So in 2018, Kenya adopted the UHC, which forms part of the 4 big agenda. In 2020, PHC was actually launched. They launched a PHC strategic framework on the existing health policy of 2014 to 2030. You're familiar with the 2030 vision. And the country's UHC roadmap to PHC implementation, they adopted as a strategy a primary care network. Actually, in UK, they have also the PCNs, which normally represent like a population of 50. And again, pharmacists were brought in to play a big role in the PCN, as they permitted the community, and they were found that's the only way they can increase access for their people when it comes to primary health care. So going forward, in 2023, the Social Health Insurance Act was passed, was enacted. It repealed the NHIF, and then the authority that was over the regulations, it's a Social Health Authority, the SHA. This SHA facility healthcare service from enlisted providers, and I read again, SHA facility healthcare services from enlisted providers by pooling contributions, ensuring equitable distribution of quality healthcare. The reason why I emphasized on enlisted providers, pharmacies as they are, because they are duka-like dawas, they are not considered as the current legislation, they are not considered as health facilities. To offer services and be reimbursed through SHIF, you have to have what you call the KML FL. That's Master Facility List. And that is what we're actually working in. I'll talk about it just in a few. Let me have the next slide, because I don't want to bore you. Now, what is UHC? UHC is a healthcare system. The UHC is as a healthcare system goal that ensures all individual and community receive the health services they need without suffering financial hardship. Just as a direct quote. And there are also 3 basic principles, probably I just mentioned before: equitable access, quality care, and financial protection. Next, the Kenya Primary Healthcare Network. This is the model that we're using. This is where essentially, I'm sure some of you already listened to this before. As you can see, the communities are at the very bottoms. The level 1 healthcare level in this country is not a physical facility, but the community level, and that is level 1 at the bottom. But as you go up, you have level 2 or level 3. These are the spokes that feed into either a multidisciplinary team or a referral hospital. The referral hospital there will be the hub, and these are the spokes. So the whole essence of coming up with this network is so that we can better utilize the resources, because some of these facilities may have one an X-ray, another one doesn't, the other one have consultants, but then when you pull up all those resources together, you can actually have better outcomes when it comes to providing primary health care. Next, please. Now again, I'm not going to go bore you with all this. Level 1, you can see is the community facilities. Level 2, health dispensaries. For those who are not familiar, health centers come level 3, and the small hospitals, then the county hospitals, that's the hub. That's level 5, county referral hospitals, and of course, I believe we have like 3 or, I don't know, there are moments like 4 referral hospitals in Kenya. Next. Pan? Did I make an error? Level 1 was the community itself. Oh, is that it? Maybe it's an error. It's Dr. Anyona, did I make a mistake there? There is no such a thing as it was just a dog. I was about to call you to find out who the hell is the certified medical clinical officers. But anyway, it was for the sake of completion. I've never worked in the government, so I could make a big error. But there are 6 levels. All I was trying to show that the county hospitals, level 4, is the hub. The rest downwards are the spokes. That's the concept. It's just the model I was trying to provide. So let's move on to the next one, please. Now, the role of the pharmacist in primary care. The pharmacists actually play a very crucial role within the PCNs. And PCNs are really groups of general practices, like in the UK, working together with other health providers to deliver integrated services to their local communities. It's a group, and the term integration is important. In the US, they call it medical homes, where you have like a team of 7 people, including MDs, PharmDs, who else are there? Nurses, nurse practitioners, and many physiotherapists. So it's a group of practitioners who actually work together. And again, you can actually see the primary health care includes essential medicines and so forth. But of course, in this diagram, this is immunization. There are many services that I provide as a primary health care level. But my focus is on the role of the pharmacist in the primary care network, the PCN. The next slide. Now, again, I'm not going to go a lot of details, but there are 9, I could identify 9 roles of a pharmacist in primary health care. Number 1 is medicine management and optimization. Number 2, chronic disease management. Number 3, medication reviews, clinical consultation, patient education and support, collaborative work, public health initiative, quality improvement, and lastly, professional development. Next slide. Now, when it comes to medicine management and optimizations, you are actually familiar with medication therapy management. Essentially, all we do is to ensure that you identify the drug-related needs and go to search for them, and you are held account for that commitment. But what you look for is, number 1, make sure that drug therapy is the most appropriate. Number 2, is the most effective. And number 3 is a safest possible regimen. And number 4, that the patient is able and willing to comply to those instructions to get better outcomes. Just quickly go through it. I have only 2 minutes left. Chronic diseases, of course, you'll be there as a primary healthcare provider. You'll be involved in actually 70%. This is important. 70% of the patients who appear in the hospitals are there to manage drug therapy. It's not because they are going there for a new diagnosis. 70% of those people you see in KNH are there just because they have failed in the medication therapy. Can I have the next slide? Now, medication reviews, there should be actual medication reviews. In SHA or in SHIF, we're trying to ensure that at least patients have at least one comprehensive medication therapy review, if not 2. Next one. Clinical consultations, these are pharmacotherapy consultation. You may get a call from the patient or from the medical doctor on a very specific consult. So you can also be consulted. It doesn't have to be a service, but this is one of the things that you do in the primary healthcare network. You can be consulted. Number 5. I have 1.5 minutes. Next. Patient education, I don't got to go through it. Definitely, you do realize your job will not only be educating patients on rational use of drugs, but also on health promotion and wellness. Thank you. Next slide. Collaborative work, you'll be working very closely with the nurses and GPs. I don't have to repeat that. Next one. Public health initiative, of course, if there are outbreaks, you'll be very much involved through immunization that we did during COVID. The next one. Quality improvement, you will actually be part of the quality control. And incidentally, when I saw the QA framework for Kenya, all hospitals are expected to provide medication therapy management. It's already in policy, but you'll be involved in the QA exercise. Professional development, I don't have to go there, you do know about the CPDs. Now, for the GPP, for sure, these are guidelines, these are not laws. We have 23, I can just summarize for you, there are 23 standards, the expected outcomes when you practice. This one, there are 23 services that have standards, respect standards, and then there are also what we call performance criteria for each standard, and then a QA framework to see how you're performing. So this one has already been circulated to you. I don't have to go through it. What is new, just a minute. What is new is, just a minute. Can you go back again? Now, this is one of the, we actually have the fiscal layout for all these pharmacies, for level 1, level 2, level 3. If you look at this one, I believe it's probably, Dr. Ermias, where is he? Was this level 2 or level 3? Yeah, it could be, pharmacies are going to be classified in 3 levels. The last level is dispensing, the other one is for pharmacy, and the other one is for specialty pharmacists. But obviously, it's a different setup like what you're used to seeing with the grills, the dukawalas. It's actually a healthcare facility which will have a master facility list code. So we have it already. There are 4 or 5 designs, even one in the hospitals that includes areas for clinical pharmacies, for those who are doing research, for those who are doing clinical toxicology. I didn't want to go to details. So lastly, the pharmaceutical care benefit package. What we did, and this is the last slide, I don't want to bore you. What we have done, we have been collaborating, PSK sponsored several meetings, one of them in Safari Park and now at Pan-Afric. We came up with a quick guide for actually costing the service model package. The other one, Dr. Nyakiba group, are actually working on the national catalog. But for the service component, it's based on the levels of practice, dispensing fee, and it's going to be based on the approximate salary per ton into Kenya shillings per hour. And this has been done for the farm tech, farmers, specialty farm, and subspecialists. This has already been submitted, but I think they are waiting for a direction from the board it is going to be attached to facilities. So this master facility list codes must be given to them, but I believe Dr. Wesley and the group are also working on that. So that's the brief. So thanks so much for the time. I'm sorry I had to do that last time.
This president is telling me I have 1 minute. Oh, so he has given me another 4. I don't want to take time. I think I've talked enough. From the time I was teaching most of you, I've done enough talking. You know, and I'm sure you have capacity to listen and maintain, so I don't have to do a lot of talking. Even my voice, you can hear, it's threatening to protest. But I just want to add 1 or 2 little things into perspective, why we are here, what we're trying to do. And drawing your attention, PSK, the bodies that concern you, PSK, the PPB, and the APSIA. How many of you know what APSIA is? Right? Most of you don't know. It's the Association of Professional Societies of East Africa. That is the umbrella body that deals with all the issues professional in this country. Engineers, doctors, lawyers, all of that. I can tell you KPA tried to apply there and they were told you don't qualify. Just for that you know. Are we together? Just so that you know. They don't belong there. They will not be accepted. Right, that cleared. So, you know, we have to relate to those bodies. Our issues, we escalate them to the APSIA at the national level because we belong there And we must know, when you send a presentation, we must know we articulate our issues through these bodies. And of course, then we deal with the PPB for our matters of regulation. And we clearly must understand the concerns of regulation, the concerns of ethics. I think we have emphasized, and we have continued to remind us that ethics is a critical part of what we do, and it actually supersedes the law. I think when I was teaching law, I must have emphasized that point. The first, you deal with the ethic issues, then you don't even have to worry about the law, because ethics deals with everything, right? Because if you have the laws and nobody wants to enforce them because they're unethical, then the laws don't serve anything. Together, we're together. So, ethics first. You've done ethics, you've done everything. It's like you say, seek the kingdom of heaven, and all the rest. I do understand, maybe I got that wrong. You excuse me if I get that wrong. But if you are ethical, then everything else falls into place. You can't even break any law, because when you hear the greatest commandment, you shall love your neighbor. You don't break any laws. You don't steal from them. You don't do nothing. So I don't want to go there beyond that. So self-regulation. We have talked a lot over the years about self-regulation. What does it mean? Starting from the ethics. When we are ethical, and among ourselves, we call ourselves to order, then that is the concept of self-regulation. When you be a neighbor's keeper, so that we call each other to account. You hold it with your position of authority. Be accountable. And fellow Atebe here will tell you, in the past, we have had occasion to call to account, even members of the board at some point, where they did not do the right thing, and we summoned them as PSK, and we disbarred them as members. Some of you will not know that. You will not know that. But that's how PSK works, and it has worked. It's in history. It's on record. We don't want to mention the names. But you can consult. We can tell you those stories. But just to know, PSK has teeth. Right? As it is, PSK can summon anyone, even if you are an employee of government, and say you are doing the wrong thing. Right? You are not being accountable to this profession, and therefore to the country. Let us not imagine that everything is in the law. It has to be. When you want to enforce those ethics, you can do very many things. I think it's very, very important. Even to the leadership that has been there, that is a message I want to emphasize. Sometimes when you hear the history told, and sometimes it's good to remind us, that under Cap 244, there are certain things I did when I was a registrar that were not strictly in the law. But because I knew the responsibility, I went ahead and just wrote a circular. And Vijay will tell you here that alone worked. And everybody is called to order. So when you're in a position of authority, be accountable. And use your moral authority to actually make sure people are doing the correct thing. I cannot overemphasize that. It is important. We sometimes look to the law. Law is not everything. You can have all the laws in the world, but you never get anywhere. Now, I have talked I want to talk about the role of policy and regulation. That's one area I think I find that we have a problem. If you think about all the problems we have in this as a profession, you'll find the source or the origin is in the policy or the regulation of the law. Having talked about the issue of the ethics. Now, when you come to the role of these things in making the necessary arrangements for us to get ahead, to get the jobs, to get the authorities we need, you find that you can identify that in the policy or the law. That means that if you are in a position, in an office, you must pay special attention to the policy. Right? You must make sure you are at the table when the policy is being made, because if you get done at the policy level, you are done. You find yourself in a place you cannot solve the problem because it was fixed, you got fixed at the policy level. Right? That's why they tell you if you are not on the table, then you are what? You're the menu. Right? The menu is cooked at when you are doing policy. So, and unfortunately, we have had the instance where in the past, people absented themselves from the policy table, and then we ended up with things going the wrong way. Right? I don't want to go into the details of that, but I just want to caution. If you're in an office or anywhere, please, the first thing you want to attend is that table where policy is being made, is that table where the law is being made. Because if you are not sorted there, then you are going to have a lot of problems. So, it's just a point to remember. If you look at all our issues where we're being squeezed out, be they the vets now who are trying to squeeze us out. They're trying to use what? They're trying to use the law. These vet meds and stuff, they're trying to use the law. Okay? So don't forget. Now, to that extent, that's why I talked this morning. You remember I talked about over-the-counter medicines. Right? Why are they over-the-counter? And how can we change that? Just the law. We say, look, here, today, we do have no excuse that we have medicines all over the place. We have the capacity now to say every medicine must be under some regulation. We cannot say people are not accessing them because we have facility infrastructure across the whole country that people can access, but within the framework of a control, a certain level of control. We are talking levels of control, aren't we? So to that extent, we create more space, even to accommodate those fellows there who are complaining and saying they're doing, instead of them jumping to be, they can go too high where they cannot. Tell them there is space. We are creating space for them there. That is strategic. So when we say create this space, it's because we want to create enough space, even for those who would like to claim that they are pharmacists. So, to that extent, I just want again to emphasize that because of this, the issue of the vet meds, because that is a topical issue. Let me address that a little bit. This morning, you've had our colleagues and my good friend I respect, my co-alumni, our friend registrar, he said it was done. And I said, no, respectively, no. We cannot say it is done. Why did I say that? And I want to bring you to attention, Dr. Amurisho, since you are here. And I say, you can say now today, was Muricho wrong to try and go to court? I wouldn't say so. But the truth of the matter is, and I can tell you, that when he did that case in 2016, the person who handled it for us, the wakili who handled it for us, did a messy job. He did a very messy job. So the magistrate, even if I was the magistrate reading that case, I would have ruled the same way. Because the magistrate administers the law. The facts you present are the facts you use to judge. You see, they say the law is a what? I don't want to use that word, but you have said it. You are the ones who have said it. If you present the judge with the fact, he use the facts you have presented them, they will make a ruling. Now, if you made the mistake of presenting the wrong facts, or you misrepresented the facts, and the judge makes a ruling, you cannot blame the judge. So where am I going with this? I'm saying, and I've talked to the president a lot about this issue. Going forward, we must ensure that when first of all, you want to avoid, the first thing, you want to avoid having to go to the law. How do you avoid going to? By making sure you do the right things to avoid the situation where you have to go to the law. Because the law becomes the last resort. That means you do, for example, what you're doing the advocacy. When these bills are being done, you make sure you're participating to make sure your views are taken as per constitution demanding. And hopefully you can intervene at that level. But at the end of the day, if everything else fails, that is when the law comes in. And nobody can tell you it is done because, the law is there for that purpose, to settle the disputes. And right now we have a dispute between us and the vets. They claim they took them then. They're using that 2016 case to justify. But from where I sit, and the research I have done, and the documentation I've done, I know for sure, and I've talked to Wakili who we work with, and we know we can deal with the issue. So I speak from a position of knowledge. So whatever was done then, we can undo it. But we have to be clear how we present this case. So every case that is taken to the court now, we are saying it must be oversighted. If you send a lawyer to go and represent me there, and you don't give the appropriate brief, you think they can do magic for you, you don't get anywhere. So we have to have a proper oversight about those cases. Before it is presented, we look at it, we interrogate the facts, and we make sure we have everything there that is going to help us to win this case. So we can do it. The vet case, I think we are on course, and we are going to make sure we recover that ground that appears to have been lost. If somebody comes to your boma and steals your cow or your goat, and you follow them, and you say, well, they took it from the boma, so it's too bad, it's gone. What do? You normally pursue them, don't you? Before they cross the river, where you cannot go, you say, no, it is mine. So we are in that situation. They took the goat, they want to cross the river with it, but before they get there, we must intervene and get it back. I think most of you can associate with that kind of analogy. So we're working towards that, and we shall be asking the leadership will be asking you the support you need, because again, this requires effort. It requires resources. And I am happy to hear now the PSK is well resourced. And if we are responsible, we can handle those things. All right? We can handle those things. But you must know the strategic way of handling those things. It's not throwing money at things, it's just being strategic. Now, and talking about strategic, I now find I'm winding up. I'm coming to winding up. Yes, I know. Strategic, when I say strategic, it reminds me of a strategic plan for this society and any organization. Let us be organized in a manner that we have a plan, and we know the objectives we want to achieve, and then we know where we are putting our resources, and we follow them. When it comes to every strategic plan has a period lifespan. For government, sessional papers and think they are 10 years. For us, we can determine 5 years, and we move on. I remember we developed a strategic plan. I would like to imagine we can interrogate this. How much have you covered? Do we need to review it? That is important for the leadership that is going to come in. We must approach our leadership from that point of view, because otherwise we'll be chasing things like, knee-jerks. You are chasing this, you are chasing this, and we are not methodical, we are not systematic. Therefore, we cannot achieve what we want, cost effectively. As I go towards closing, I cannot miss talking about the pharmacist image in this journey. The pharmacist image, all right? When you all come here in the morning and you come dressed, and I would imagine most of the people want to be coming decently dressed, okay? Because if you don't, people look at you and they start wondering, hey, wait a minute. The image is critical. And even what the dress code, you talk about dress code. So I want to say this. We worried about this from a long time ago, about the image. We worried because when we went into those situations where you are medical colleagues, and you are told this is a doctor, this is a mister, and we said no. Nobody knows this mister, where is this coming from? Why is it different from this other one? That is why we fought for the issue of the title. For those who think where it came from, it is the reason that we found that if you don't have that immediate recognition by name, by title, then you have a lot of work to even to put your case. So the war we fought was not an end in itself. A doctor type was not an end in itself. It was supposed to introduce you to the audience who can now pay attention to you. And then you put your case. And you put your case not just by sitting there, entitlement, no, by showing, yes, you can do this, and you're making a difference. You are making an impact. But at least the door must be open for you. If I start telling you the issues we face so that we say, no, this has not happened, I can take the whole day, but I don't want to do that. So the image, therefore, we asked for the title. And I remember 1987, I presented a paper at the CPA, and and I have these documents, and I'm going to give them, and I wish them to be published, so that all of you can see where we are coming from. Now, from there, we went on to develop the instruments, necessary instruments, the oath, right? You understand? We developed the oath so that when you have the doctor, then you are swearing to some oath that you stick to the ethics. We developed that. And the third thing, I insisted, we must have it administered where everybody can see, at the graduation square. How many of you had an oath administered at the graduation square? How many of you were sworn at the graduation square? You know, before that, there was nothing. When we developed the oath, they say, you administer it to yourself. We say, no, it has to be in a public forum where the public can see. This is the man who is being sworn in front of everybody. When everybody goes there, so what? So it makes a lot of impact. You know you have sworn to something. Okay? And those are the achievements. To do what? In order so that image, we commit ourselves and we get respected. That image, you must jealously protect that image. Even at your work situation. Make sure when people see you, this pharmacist is a pharmacist with an image to protect. When you're working, make sure people appreciate you. You're a professional. Not by demanding, not as entitlement, but how you carry yourself and the way you do your work. And the people really, truly see. You are creating the space by being responsible. Right? So finally, the role of we fellows, if I can close with that we have committed ourselves as fellows, that we want to help where we can, because it is our more responsibility to help where we can. To that extent, we've had our meetings as a committee of fellows. The Constitution provides for a committee of fellows. For those who don't know, there is a committee of fellows in the Constitution. So we are part of that committee of fellows with a responsibility to offer advice and oversight over things. So whenever you have issues, whether they are disputes, we have done it before, where you say the parties who are disputing, come and we sit with you. And we advise this is how we do it, so that you maintain order, you maintain, and you must have that respect. So these people, when you see them there, don't just think they are old men. These are people who have done things. They are people who have made some contribution. And they are ready to continue to make this contribution. So please, whenever you are, respect them. Don't just look at them as just old fellows who deserve to be pushed off the table. And we have assigned ourselves those responsibilities in the society. I was, some of those meetings, I was assigned the job of following up with the policy and legislation. So when you see me in that space, that is my mandate, to make sure that in this team, I follow up. As long as you support us and the leadership asks us and provides the necessary facilitation for those things, we can assure you we have your back. We can assure you we shall continue fighting, that this space does not continue to be encroached by anyone. But you must also have the courage. You must also have the courage to stand and say, don't go beyond that. We want to thank you very much. We want to urge you to continue supporting. In the future, it may look gloomy, but it's not gloomy as long as you remain united. As long as you young pharmacists work together with your seniors and your elders. I can assure you there is nothing we are not going to achieve. Thank you very much.
Now, I happen to try to get solutions to problems, answer the questions. That's why I'm standing here, to answer the questions, as much as our colleagues are also answering the questions. So I will bell the cat. So before I go to bell the cat and to provide the solutions to your questions, I want to announce that I've spent the last 5 years creating jobs for pharmacists. So for those of you who are qualified to teach in a university, come to the School of Pharmacy in Kisii and teach there, because that is the work I've been doing the last few years. Number 2, can you apply to become a fellow of the Pharmaceutical Society of Kenya? The simple answer is, what answer did you get? As the individual, you may not apply. You cannot front yourself that I want to be a fellow. You must be proposed by at least 2 members of the Pharmaceutical Society of Kenya who are in regular standing. That is Schedule 7 of the PSK Constitution. If the 2 are members and one of them is a fellow, then 2 are sufficient. If you don't have a fellow, then you need 4 more. That makes 5 members. Okay? So that's the first question which was asked in the morning, and it has been addressed. Number 2, question number 2 that was asked, how can we get more business in community pharmacy? How can we get more patients? There is a lot of competition. Is it possible? Is it possible to solve that problem? We tried it. When we qualified as pharmacists a few years ago, we used to carry cartons in the store. Then we took a step in 1989, and we converted ourselves to pharmacy doctors. Salaries moved from 3,030 to how much are we earning now? 100 and something. The second thing that we did, we introduced the professional oath, which you take, all of you. Number 3, Dr. Kamamia Wamuricho, simama. Huyu ndiye the first person to advance the Green Cross. Tulitengeneza nikiwa chairman, he went around the whole country popularizing the Green Cross. Why? Media campaign, Tumeweka Green Cross for every pharmacy which is being run by a registered pharmacist. And we got positive results. Lakini sasa hiyo ilipotea pahali hatujui iko wapi, but we need to be consistent. Media campaign, identifier of authentic place where one can get the quality medicines, and with a hotline number where patients can actually complain. We need a culture, a professional culture for Pharmaceutical Society of Kenya. That is why we introduced fellowship awards. We used to have an annual dinner dance. We used to have the making of the chairman. We used to have a chain of office. Iko wapi, Mr. President? We will need to be in a chain permanently from day 1 to day 6 of the symposium, so that we can see huyo ni president anafanya nini, anapita. You don't wear these ordinary things which are kept in the pocket, this one. President has to wear something different. Chain of office, because it is very heavy responsibility you have. The chain is also heavy, it's about 1 kilo. That's why you are not carrying it around. So, chain of office. And then we also introduced forms of address. Uwezi kuita wewe, esteemed colleague. Anybody who is a pharmacist is your esteemed what? Colleague. Kama ni mzee kama huyu, they are respected seniors. Wale wengine wakubwa kidogo, with a registration number which is smaller than yours. How do lawyers respect each other? You can see respected senior, my learned friend, my learned brother, respectable brother. But kudugiwa wa pharmacy, anybody is a pharmacy. Wewe daktari wewe. An old man with gray hairs, kama Hudson Maina. You are calling, you qualified 2 years ago and you are addressing, wewe daktari wewe. No. Respected senior. Let us have some decorum, the way we conduct business. If we respect one another within the profession, then the public will respect us. Are we together? They will respect us. Anyway, we have a code of ethics. It will deal with that issue. How do we dress at work? Are we in proper dust coat with the name tag here? So that if a patient comes to your pharmacy, you are standing with your assistants. Can they tell the difference? They just see, they can call even your assistant daktari, because the way you appear is different. First question. Let's have the first question to the fellows.
Yes. Sorry. Thank you, Dr. Atebe, for recognizing what we did with the Green Cross. We have come from very, very far away. In actual fact, even now, this is when we are doing bigger things than we did. Now, Dr. Ndemo, there's this thing that's coming about under the chief. We normally say that where we come from, if you are a farmer, it is easier to control your goats when they're in the shed than when they are outside. Now, the pharmacy benefit package, if you look at the way it has been planned, because this is the only thing that is going to take the pharmacists out, is that it's going to include even the pharmaceutical technologist. My greatest worry is this. Are we going to say that anybody who has got, who is registered by the Pharmacy Operations Board, and has a community pharmacy, is going to benefit from this issue? No. In February and March of 2024, 3 months ago, for the first time, the Pharmacy Operations Board registered 3,500 new premises. This is after the Gachagua, the Deputy President's directive, that police officers and chiefs raid the illegal premises. So all the quacks, 3,500 of them, got licenses from pharmaceutical technologists. Is there anybody from, where is because I don't want to be, you know, in the morning I said about foreign GMP, I was told that I was wrong. That was the number. 3,500 chemists were registered. And then after that, 2 weeks, 1 month after that in April, the Pharmacy Operations Board started moving around, crossing the same chemists. It had corrected 15,000 from, because of absentee superintendents. When I raise this issue, the president is aware. You see, you cannot license quacks. You clean up their business. And I've told you there are 3,500. Zote sikona. But was a pharmaceutical technologist. Today, if you went outside there, Dr. Ndemo, you have talked about 500 pharmacists, learning chemists. You could not be very far away. What work of our community, the whole country. We have got about, is it 9,000 plus chemists, Mr. President? So if you remove that, you are going to find that almost 80% of the chemists in this country are run by pharmaceutical technologists. And absentee pharmaceutical technologists who are going to be run by quacks. So my worry is this: if you do not move forward, the whole of this pharmacy benefit package, 90% to 95% of it is going to go to the quacks and to the pharmaceutical technologists. So, because we are here, and the pharaohs are here, I think we have to address ourselves to that issue. Otherwise, when we meet here next year, God willing, if you be arrive, we will not be talking about the pharmacy benefit package having been taken over by quacks and pharmaceutical technologists. And this matter, if we had all this, because I've seen the way it happens in South Africa. I've looked at the model in UK, in US, in Denmark. It's the thing that's going to benefit. For example, if I can, because we are all grown-ups here, there's nobody who is a kid here. Over the last 10 years, look at all the private hospitals where you come from. Si zote zimeenda because hiyo pesa wamepata from NHIF. See about ambulances and all those types of things. So this is our time now to maximally benefit from the pharmacy benefit package, hoping that we will not be crying that we have not been paid. Because obviously that's another issue that is going to come up, the chief. Yeah. Then before we start this issue, because I don't know at what level this is going to be handled up, because I can see as those people of us who are going to get into this package issue, I don't know, we require now to have a serious engagement with the government. Because chief has taken over the liabilities of NHIF, as per the letter that was done last week, but one. You know, NHIF owes providers more than 100 billion. So now we are wondering how is that matter going to be taken up, so that the providers do not suffer. Thank you very much.
Asante.
Question 2.
Asante,
Question 2. Let's have 3 questions first.
So we'll have 3 questions. I'll come here then there. 4.
Thank you very much for the opportunity, honorable fellow colleagues. Mine is a little bit kind of asked to give us some advice on some things which maybe I might be ailing our profession as you know, we have different levels of practice. What Mauricio is saying is one aspect of it, but now when we talk about your experience in terms of the years you've been in practice, have you been in a position where division has engulfed the professionals in the pharmacy space, where we have different groups? Like you've seen currently we have public sector pharmacists, private sector pharmacists, lady pharmacists, versus others who are neither here nor there, not known, and then and young and old. From your experience, what do you see this trend? Where is it taking us? Is it the right thing to do? Or for me, I feel we need to address it. Maybe you may not get the chance again on a forum to advise us on this. You need to come out very strong, reprimand us where we are going wrong, because I think if there is a time we need one another most is now, because of the changing trends in terms of everybody fighting for pharmacy. Thank you.
Sante. Sorry.
Yes, thanks, Mr. President, and the pharmacy fellows who have come to our PSK International Conference. My name is Dr. Peter Ngwai. I want to ask a very brief question to the fellows. How can the fellows increase their visibility so that the pharmacists, like the ones who are here and those who are not here, can benefit from their wisdom? Because I think we hear of the fellows, we see them maybe in a conference like this, and that's just like all. Even the programs which have come out, Fellow Atebe, even Fellow Ndemo, the programs they are doing, Fellow DSK, it's like they are personal, they are just out of passionate. But it's simply not like it's out of the fellowship. But we want to see that. And again, this is 30% of the fellows. Where is the 70%, and what is their role and input to the PSK? Thank you very much.
As I said before, we were actually in Naivasha, and we have classified pharmacies into 3 levels. The lowest level is what we call the dispensing pharmacy. There's no MTM or medication therapy management service that go on that level. So when you're contracted, there will be no reimbursement for MTM for the pharmacies that will be run by PharmTechs. But when it comes to the what's it, level B, whatever the second level higher up, is that's run by pharmacists. They'll be providing MTM, which is actually reimbursable, and the rate at which we worked with Dr. Samson Kohora was based on general salary. It was very crude because we were really panicking. They were actually closing like on 29th of June, of May. But then I was again reassured by people from HPT that the pharmacy package is not too late. So I'm not sure where the truth lies. But all the same, we submitted something to do with for reimbursement for the clinical service offered by the pharmacist. So in terms of level of practice, it's very clear. The generalist pharmacists, and then the specialists, and then the subspecialists. There are all those levels. There are 4 of them. So, so we're just hoping that, but I was disappointed because in the schedule, those clinical services are not explicitly stated. But I'm hoping that they're going to revise that, because we were very adamant that they really make a reference. Otherwise, when it comes to primary health care, remember, even the community health promoters, CHPs, they be carrying medications. They're explicitly referred to in the schedules. So where are the pharmacists, the nurses in the community? They are referred to. But once again, we are hoping that was, my frustration was the troughing between the pharmacy board, the NHIF or SHIF, and HPT. Apparently, there is no, I don't know, we're working in the silos, but hopefully they promise they will be working together, and there is a committee that has been set up to talk about pharmacy benefit package by HPT. I will give you more information once we start meeting. That's the match that I can give you at the moment.
Thank you, Honorable Fellow. Let's see the members of this SHA committee. Members of the SHA committee? The chief, of course, it is now going to SHA from NHIF. It is going to the authority. How many are participating in this? The chief? Oh, there is one, Gatare, and who else is this? Now, this is the suggestion. You know, we can't solve everything here, but this team should not be disbanded. It should continue. It should be alive perpetually. Why? The criteria we are talking about, and please try to include the chairman of the distributors. The CAPI should be there. The KPDA, yeah, should be there. All the key area, key sector, subsectors of the pharmaceutical sector should be included, so that when we come up with the criteria, we carry everybody on board, both public sector and private sector, as we move along. So this is something which is work in progress. You can't solve it just at once. And we know there are always improvements going on. Chair, would you like to carry on with this committee and add some more? Yes, please, Mr. President, kindly take note, because we need really to provide solutions. Visibility. You didn't see me here on, did we start on Tuesday? On Monday. I was not here for the most of the week. I just arrived this morning to this particular conference. Why? Talking about visibility. I was charged by the leadership to engage senators at the Pride Inn. So I was there with the KEPSA and the Senate at the Speaker's Round Table. Talking about visibilities, I was actually sent there in my capacity as a fellow. And Mr. President has promised that we'll have consistency in that kind of representation. Number two, the chair is actually, for this initiative of reimbursement of the pharmacy package, is a honorable fellow. You look at the legal and ethics, who is handling, you can raise, although you are my respected senior, is a honorable fellow Dominic. Now, there is only one aspect which is missing. It is called understudy or mentorship. So we are requesting, Mr. President, that we get young colleagues who will work with us. It is very good that I had Mbau. Where is Dr. Mbau? Yes, he is right at the back. Let's put a round of applause for him. He was with the honorable fellow at the Pride Inn, trying to persuade the senators to have a favorable, a soft spot for the pharmacy profession and the Pharmaceutical Society of Kenya. And we are going to make good progress if you advise the incoming team to continue in the same trajectory. So visibility, yes, we are doing it, but we can only do so much. If the incoming say stop, we'll definitely do what? Stop. But we want to be sure that we are going to continue. Honorable fellow Dominic, please come and address 3 more questions.
Thank you. The third question was about divisions within the practice or within the profession. And I think I alluded to that in my earlier comments. There is nothing you're going to do if you are divided. I don't think I need to emphasize that point. This is gentlemen. United you stand, divided you fall. So if you divide yourself by whatever criteria, whether it be tribe, whether it will be height, whether it will be by age, or whatever, then you fall. So that is one thing we must forget. And if we ever did that in the past, please let us go, whatever church you go to, and you utubu, you do what? Utubu hiyo makosa yetu, unamuuliza Mungu unisamehe hiyo kwa sababu ukileta maneno hiyo division, alafu hiyo profession ianguke, hata ukifika kwa Mungu anaweza funga hiyo mlango. Aseme wewe uliharibu dunia yangu hapo. Si ni kweli? So let us commit ourselves to avoiding anything that brings division for whatever reason. Tuko pamoja? How many of you are willing to do that? Let me see I see some of you don't have a hand to raise. I will repeat. How many of you commit yourself to working together so that we stop this maneno? Bwana Moniki, I see your hand is up. You know, it is important. This is important. That we cannot go back there. We must never go back there. Now, the second question I want to address about teeth for the disciplinary mechanism. You know, teeth means you can bite. You know, you say, bure, haina teeth. Now, when you talk about teeth, the teeth, principally, the law gives you teeth. That is where the force of law, here the force of law. The law is authoritative. Those of you who are taught law, the law is, once it is enacted, it is authority. It can kill you. You know the law can kill you. Are we together? You know the law is an entity you create as a human being. The society creates law. Right? And I'm not going to lecture here. But the law can kill you. It has force. How does it kill you? Inasema ukienda kotini, anasema enda huko kamiti na unyongwe. That is the law killing you, right? Sini kweli? It has teeth. Now the other thing that should have teeth, and I talked about the moral law, which is the ethics. All right? And I said it is the higher law of the two, right? Secular law and the moral law, which is what ethics is about. And I say the moral law is up above. And that must have teeth. And that is why I said earlier, if we put ourselves under the pharmacy oath, you have sworn. And to the extent that you have sworn, and if we are a serious society like we are, then we must hold you to account. And I alluded to how we can do that. And we have done that in the past. Right? That we shall summon you, wherever you are, no matter which office you are holding as a society. We have that moral authority. Tutasema tumekuita hapa. Na tuite press. Tuite press weme nyinyi sisi watu tuko kwa nyumba yetu, and I hope even president is listening. Okay? Sijui, and I don't know whether the candidates are listening. And can I say for avoidance of doubt, I'm not standing for president. Because I had rumors to that extent. Please, let me clarify that. I have been president, and I don't want to get into that space. I will help you consulting, but I cannot go for that. I can't. I'll be messing things up for me. So, I am saying this, that we as a society can actually have the teeth. We have the teeth. It is just the commitment to do it, right? If we to summon you and we tell the press to come here, this man is not one of us. Do you know those are teeth, right? I'm going to say this person, tuandike picha yako tupeane kila mahali, ichapishwe huko. Huyo si wetu. You deny you. Hiyo sio teeth. Bali utaonekana huyu ni kama lepa. Upatikani mtu utakuongelesha. Tunaelewana? So it is upon us as a leadership and upon us to say, if anybody was to do anything that demeans the society, we have the means. We have the means already, and we have done it before. Tuko pamoja? But and with the link with the law now, we can even go to the regulator and say, this person will never have a license. Tuko pamoja? Daniela, we have done that. Before you are given that license, are we together? Before you, the PSK must approve and say, yes, we started that, Daniela, remember. Right? Hiyo list italetwa, tunasema ndio pelekwa kule, tayari tumesema ni sawa. Tukisema hakuna haku. Are we together? Now, the third one was about the directorate versus HPT. That question has been asked, and I raised the question yesterday when Dr. Menge was here. And it is good when I was raising those issues so that we can sensitize ourselves to this. And I said the session of paper number 4 of 2012 provided for the establishment of the Directorate of Pharmaceutical Services. And for avoidance of the drug policy in 1994 had done the same thing, but it was never implemented. And the session of paper number 422 noted that fact. It was never implemented.